Welcome to Caring for You. This podcast celebrates everyone who gives, receives, and needs care. I'm Patty Williams of Homecare Resources Now, and we're diving into stories, insights, and moments that remind us of why caring for others and ourselves still matters. Thanks for joining us. Welcome to Caring for You. This is a podcast that concentrates on caregivers, professional or otherwise. We want to bring you information from the community from all areas of care. And we're going to go into a very interesting level of care today. It's one that I think a lot of people would like more education on. And so today I have Dwan Kelsey with me today. She's the Director of Community Engagement with Transitions Life Care here in Raleigh. So Dwan, welcome, and I'd like for you to introduce yourself.
Thank you, and it is a pleasure being here. I am Dwan Kelsey. I am a nurse practitioner, and I serve as the Associate Director of Community Engagement at Transitions Life Care. I've been at Transitions for about 14 years, and so it is a pleasure to not only serve the 10 counties in which Transitions serve, but the community at large. So thank you for having me.
Thank you so much. I just love the work that you all do. I was recently able to visit over there when Nina Freeline was there doing a reading from her book. I enjoyed that so much. But the other occasions when I came over was because I had friends there that were transitioning. And it was such a lovely environment even then. So I'm just so happy with the work that you all do. So speaking of hospice, how would you define hospice?
That is an interesting question, and we are oftentimes posed with that question because there are a lot of misconceptions and myths and assumptions around hospice. And so what we have to remember is that hospice is a medical plan of care. So I'll use the example of you take a diagnosis such as congestive heart failure. And when a patient is diagnosed with congestive heart failure, that patient may be seeing a cardiologist. And because of the different complications that may occur with congestive heart failure, that may include, the effects of kidney disease, and that patient then is seeing nephrology. And so it could be various advanced specialists in which that patient sees. But when that patient has decided that they do not want any more treatment, or they have decided that I've had enough and I just would like comfort measures, then that patient will transition into hospice, which is another advanced specialist. It is now just called hospice care. It is for those folks that are in that terminal illness phase. And I will say that terminal illness doesn't necessarily mean the last 6 months of someone's life. We tend to hear that is when you're in hospice, it's the last 6 months of someone's life. Although we do not have a time capsule when someone may leave this earth or make that transition. The purpose of hospice is to support those patients during that time, whether it is 6 months, whether it's 4 months, whether it's a year. It doesn't matter. The terminal illness phase can vary person to person. So hospice is really an overall medical plan of care for when people decide that they do not want the current plan of care, but they would rather have a comfort plan of care.
Oh, that's wonderful. As you were speaking, I thought about palliative care. Can you tell us the difference in the two?
Sure, absolutely. Palliative care, the word palliative comes from the Latin phrase of pallium, which means to cloak. And so what we mean by that is that when a patient is in that trajectory of illness, of serious illness phase, and let me kind of just back up to provide a little more context. When we talk about a chronic illness, we go from a chronic illness to a serious illness to terminal. And so when that patient has transitioned from chronic to now serious, then palliative care is a medical option as well. And so in palliative care, that patient can still receive the treatments that they may be getting, chemotherapy, dialysis, medications, whatever their plan of care. Palliative care is that supportive, consultative medical care that helps to support the patient and their families as they are making that transition towards the trajectory. So palliative care comes in and asks those hard questions around who's your healthcare power of attorney. Let us help you facilitate that conversation. How can we help you with your advanced care planning? What do you want to do if you should make that transition? Do you have a do not resuscitate? Do you have a most form? Introduce people to the 5 wishes. And so that is the part that palliative care plays. It is in conjunction with whatever treatment that patients may already be receiving.
Yes, when I was doing home care and sending folks into the home, I had a client that chose palliative care.
Mm-hmm.
She had been through so many doctors and they were fragmented at the time because people really weren't doing EMRs. And when she got with palliative care, she got better.
Yes.
They,
Yes.
streamlined her medications, and she had one doctor that was in charge of everything. And she really
Yes.
lived the last 4 to 5 years of her life more comfortably
Yes.
because she chose palliative care. So that was one witness that I had to it. And I was just so amazed at how well she did. Now, it took her a while to make that decision, but once she did, she was just all for it.
And we have the research that supports exactly what you're saying, is that research supports that when patients choose hospice care or even palliative care, it increases the quality of life. And so that is where we start to have that conversation of quality of life versus quantity. So I'm glad to hear that you were able to witness that.
Yes. So, what would be the right time for someone to ask for hospice care? Or what is the right time to make a decision that you're going to choose hospice care?
Sure. The right time to make that decision, I'm going to rephrase that a little bit because I'm not sure if there is a right time, because we understand that the journey of serious illness has its ups and its downs, its valleys, and its peaks. And so and people are in different spaces during those times. And so we definitely want to recognize that it includes more than just this is the time. But I would answer that to say that as we look at, as people are making that journey through, and there are increased hospitalizations, there's increased changes of medications, changes of plans of care, where you have exhausted this medication. Let's try another medication. Let's try another medication. People are getting weaker and functionality has decreased, where that patient is unable to enjoy things that they used to be able to enjoy. And so when we speak about the quality of care, we have to ask patients, what does my quality of care look like? Is this how I would like for it to be? What are our goals of care? And so when we start to have those sometimes challenging and difficult conversations, is when we can introduce palliative care or even hospice, depending on where they are within that trajectory. So to answer your question, when is the right time? It is always the right time to start having conversations. And so when we are open and when we are receptive to the conversation, and then we add where patients are with the conversation, then the right time is that whenever they are ready to say, this is what I would like, whether that is palliative care or hospice.
That's great. So, what do you find are the biggest misconceptions that families have about hospice
Oh,
care?
oh my goodness. Wonderful
Yes.
question. There are lots of them. So I will just name a few. One is hospice comes in and they kill the patient. And I hate to use that word, but that is the word that is typically used. Is
You're
that
correct.
hospice comes in and they kill. Hospice came in and my loved one died within 3, 4, 5 days. And
Mhm.
so to kind of debunk that myth, what we know, what research has shown us is that when we make that transition, when we're able to make that transition, when we're on the trajectory, and I just want to be clear that this is not an a acute tragedy. This is individuals that have gone through your cancer, individuals, your dementia, your COPD, your CHF, your neuro, your ALS, those this so I want to just be able to create that
Thank you for
distinction
that. Thank you.
between acute and when
Mhm.
something tragic happens like a heart attack versus someone that have gone through this for months or years. But when we see people that are in that when we see people that are in that trajectory, we find that people feel like that hospice comes in and kills them.
Mhm.
But research has shown us that people want to make that transition in a peaceful manner.
Yes.
The body does not want to make a transition in a chaotic state.
Mhm.
It doesn't want to make that transition when it's in a lot of pain and anxiety and in a restrictive state. The body wants to make that transition when it's calm, when
Yes.
it's peaceful.
Mhm.
So when hospice come in, we introduce and we administer medications that create that environment so that body can make that transition in a peaceful way in which it was intended and created
Well, that's a
to
beautiful way
to
to
do.
explain it.
And
Yeah,
so we
beautiful.
have to be mindful of that. And you know, when hospice, if you choose hospice and they are introducing these medications, the medications are designed for what was created to happen naturally, or how it was supposed to happen naturally. In addition to other myths is that the whole morphine. Now we can have a whole conversation about morphine. Um, but people are very hesitant to morphine. People are very protective of, I don't want my loved one on morphine. What I will say about morphine is that morphine is not the street drug morphine. This is another form of morphine. It is a
Mm.
liquid form of morphine. It does not stay in the body like the pill version of morphine or even the IV version of morphine that a lot of people may be familiar with. It kind of goes in, does what it needs to do, and then it exits the body. But if people have already been taking drugs such as oxycodone, Percocet,
Mhm.
Norco, they've already been on morphine because all of those drugs are have a derivative of morphine. So a lot of times people are not new to morphine, they just don't know they have been taking it for knee pain or back pain or after surgery or something like that. They've already been introduced to morphine. So those are two of the top misconceptions or assumptions that I have found. There's many more, but those are two of the top ones that I found that a lot of the community may have.
Yes, that is great that I know you didn't want to use the word kill, but that's what the family members are using. Maybe not in front of you, but that's how they're arguing
Yeah.
with each other about it.
Mhm.
And I love that explanation about the morphine. That was really good for people to know, and it would make it less frightening if they
Mhm.
see, mom's been taking oxycodone, for the last 6 months. So this is just a different
Correct.
form of it.
That's correct.
I've also experienced with some clients where a family member was on hospice and they were given a kit that had medications in it that they were able to use. Can you talk about that just a little bit?
Sure, sure. You're referring to the comfort kit.
Yes.
So when a patient is admitted to hospice, within 24 hours, a comfort kit will arrive from the pharmacy. And it has about 7 drugs in there. The purpose of those drugs is that we understand, again, we understand end of life and serious illness. And so we know that as people make that journey through, that they may not be able to swallow anymore, but they still need the medications. They may not, there may be body functions that may decrease. And so, but they still need medications. And so in that comfort kit, morphine is a part of that comfort kit unless someone has an allergy to it. But morphine is a part of that comfort kit. Anxiety drugs are a part of that, because we also understand that patients, that is not unusual for patients to have restlessness and agitation and anxiety, things like that happen. That's just what happens at end of life. That is nothing unusual. We are expecting those things to happen. And so we are prepared for that by having those medications in the comfort kit. There are suppositories in there. One is for constipation, because one, the motility of the colon in which we are able to have bowel movements decrease as we journey through. And then in addition to that, medications can cause constipation. So we still want that process to happen, because that is a natural process of getting rid of toxins. That's how, one of the many ways that our bodies get rid of toxins. And so we want that same natural process to occur even when patients are headed towards end of life. And then there's Tylenol, which is a suppository as well, because pain may still be an issue, and temperature, an elevated temperature may be an issue as well, as we understand that at end of life, the hypothalamus kind of makes its changes, and that will increase the temperature. And so we have suppository for an elevated temperature. So those are drugs that are within that comfort kit to help patients journey, and also to help families when they are 2 o'clock in the morning, or what do I need to do at this time? You go to that comfort kit. You are educated about that comfort kit prior to it being open, but then you feel comfortable as to when those medications need to be administered.
Thank you. Well, in the cases that I saw where there was a comfort kit, the family members were reluctant to use it. And so they need to be encouraged. But even if you train them and you encourage them, they may think that they're going to hasten the person's passing or whatever. But I know that a lot of them are just full once the person passes. They've not used it. I know you all see that a lot.
We see that a lot. We see that a lot.
So what does quality of life truly mean in hospice care? What would that mean?
I think that I would define quality of life as it relates to hospice care very subjective, because people have their own meaning of what that is for them. Now, I'll go back to research, and that research has stated that at the end of life, people that are headed towards end of life, or in that stage of what we define as end of life, that people have, like, they want to be a personal relationship with the creator, or whom they consider to be a higher being. Research also said that people want relationships, whether that is a personal relationship, they really want that to be mended if it has been severed in some ways. People want peace, whatever peace may look like to them. So when we say quality of life, we have to ask we ask that question of those that are going through the end of life. And that is important to us in hospice. We ask those questions early on. And that's why I'm not sure if this is part of the questions here, but that's why it is important to bring people on to hospice as early as possible. Any
Yes.
time is a beautiful time because we are here to support and to assist that patient and family. However, to benefit from really that hospice has to offer, and one of those is just communication and understanding goals of care. What do you want? What can we help you with? You know, we are four dimensional. We are spiritual, we are emotional, we are social, and we are physical. And so hospice has the opportunity to hit all four dimensions 100%. And so we got to sit and have conversations with people to understand what does quality life look like to you. And then as we assist and support and love on people, we keep in mind what their quality of life is for them, and we try to assist them in that way.
What does a good communication between hospice and family members look like? How should that actually work?
That should work just like it has worked throughout anyone's journey in this healthcare system. Communication is big. Communication is just not one-sided. And I am a provider, and so, but I just don't want to be the only one making that decision for family members. Just don't take what I say. Let's have a conversation, because I don't know, as providers, we don't know what your environment at home may look like. If we're not sitting down and having those conversations, we don't know what your quality of life or what your goals of care may look like. But all of that is important when we talk about how are we to best steps to take care of individuals. So with communication, it has to be a two-way street. And so you have to be able to provide the hospice providers or the hospice people with everything. What are you thinking? What do you want? What are your desires? What do you not want? What are the questions that you may have? What are you reluctant to? What are you open to? What are you? Those are the type of communication. And then for the hospice system, then we have to listen. But then we also have to educate, because as it goes back to the myths and the biases and the miscommunication, we have to make sure that the community has the correct and the informed information to make the appropriate decisions for themselves or for their loved ones.
That's great. And that communication is really key. And even though you all come out and you explain and you tell them, I've known of some cases where a person was on hospice and they agreed to it, and the family member, when they started to transition, they called EMS.
Absolutely.
And how should that really work? What is the training on that?
Well, from day one, we ask that family members, loved ones, call hospice first. So that is, and at each visit, whether it's a social worker visit, whether it's a nurse visit, whether it's a provider visit, that is reiterated. But we also recognize that this is an area that people are not familiar with. And our culture has trained us to dial 911. And so we recognize that may happen. We recognize that there's fear in people, and regardless of the education and the information that you have given people, there still is fear. And so we recognize that and we respect that. And so there's a lot of communication that happens. But I will say, for the most part, and I think research actually supports this, and I know on transition side, calling of 911 is definitely not a norm. We probably can almost count the number of times that happens, relatively speaking, to the number of patients that we have.
Right.
So that is very a rare occurrence. Does it happen? Yes, it happens, but it does not happen at that level.
Great. As you were speaking about that, I was thinking they could be calling for support
They could be.
because I've been gotten there in cases like that where EMS came in and they fully know what's going on and they behave in a different way. They go, okay, well, we see the papers and this, that, or the other. So the person may just not want to be alone with that individual when it happens, if it's a case like that. So that's another way to look at it. As you were speaking, it made me think of that.
No, absolutely. And speaking of EMS, we actually train, and we're in Wake County. So we
Yes.
actually train Wake County EMS. Our Wake County EMS students come through Transitions Life Care, and we have this same open conversation with them as to what should you all look um, for a patient that should call that's on hospice. How do you communicate with us when you get to a patient's home? And so EMS is very open to an understanding of our hospice patients. So we definitely have a wonderful working relationship with our EMS department.
That's great. Well, I want to shout out to them because I've seen them on a couple of occasions where they handled themselves
Yes.
very well when they came in on a case like that. And nothing extraordinary was done. They were just there for support.
Correct.
So I'm happy to know that you all trained them and they really got it.
Yes, yes.
Yes. So you work so closely with death. What have you learned about death being in a hospice organization?
That is a great question. I came from an area that I came from internal medicine, and I was trained to save people, and I use the word save in quotes. But I was trained to, you give people medications, and if that doesn't work, you give another one, and there's another plan of care. And so, that's how I was trained. And so I came to Transitions with that mindset. But it has been a wonderful journey for me because one, it has offered me the opportunity to look at my own mortality. Secondly, it's offered me the opportunity to look at death in a very beautiful way. That it is to me, it is no difference than the birth of a child. And, we oftentimes hear, we rejoice for the birth of a child and we cry for the death of a loved one. And all those emotions, either way, are acceptable and respected. But I have learned that death is one part of life, but it doesn't start there. And it can be what we call in our world, the hospice world, a beautiful death, a beautiful transition. And what makes it beautiful is when people can make, because we are all going to make that transition.
Yes, we are.
But when you can make it in a peaceful environment, when you can make it on your own terms, we may not know the day nor the time, but you can still make it on your own terms so when that time may come. When family members are on board and family members are at peace with the decision that that patient has made, that this is what that patient wanted, it went well, it is going well, and that patient is at peace, that's what I have learned about the death process. And I will say on the other side of that, when you see it not go well, and we do have many cases of when it not go well, you appreciate the good deaths. You appreciate what that can look like when we put the proper things in place.
I love the terms you use, a good death and a beautiful death.
Beautiful.
You don't typically see those together. So that's a great perspective. What type of support can you provide for family members that are trying to choose hospice, but they're feeling a lot of guilt?
Oh, that is a good question. Um, I would say in general to family members that are trying to choose, one, reach out because there's an opportunity to have conversations even prior to making the decision of putting someone on to hospice. It's just reach out. So the same way that you would vet a surgeon or the same way that you would, research someone else, you can do the same thing with hospice. Like, what do you all, let me get an understanding. This is what I heard. Let me get an understanding before you come and provide care to my loved ones. So I would say, first of all, reach out. Then I would say, when you reach out, be open. Be open because there are so many misconceptions and misunderstanding and myths out there that are not true. They are not true.
Yes.
And there is a reason as to why everything happens in hospice. We have evidence. We are just as evidence-based medicine as any other medicine that is known.
Beautiful.
And so we are evidence-based. So when we talk about food, there's a reason, there's evidence why we don't support feeding people. There's evidence why we don't support getting people up. There's evidence why we choose to take people off of Lipitor and high blood pressure medicines and things like that. There's evidence why we have chosen morphine as an option for pain. There's evidence behind that. It's just not something that I think this is what they like. This is what we have. No, this is evidence-based medicine. So I would say reach out and be open and be receptive to understanding, getting a full understanding of what hospice really, really is. There's a lot of tools available. One, Transitions Life Care actually has a documentary. It's called An Act of Love. I'm talking to my loved one about serious illness. It is on our website, transitionslifecare.org. Go to resources and then to community, and it's right there. It's a wonderful documentary. It's a 25-minute documentary, but it gives you an opportunity to hear from others, hear from the community on how to have that conversation. We have a lot of programming at Transitions. We have the Unbroken Circle, which kind of talks about how to have serious conversation and understand that in a faith-based perspective. So what do our churches need to be talking about? How can they incorporate end of life and serious illness within ministries or start a brand new ministry? But many times it can be incorporated within ministry. So there's many ways that, but when you talk about guilt, when we include guilt in there, I think that is truly an opportunity for people to just reach out and let's just have that conversation, because it may not always be guilt. We kind of give it the name of guilt,
Okay.
but it may be something else. We just don't have the language to define what it is.
Great. That's a great point. So once that family decides that they want to get hospice, what does that first visit typically look like?
Yeah, so I'm going to say this from Transitions because every hospice is not the same. So every hospice
Thank
doesn't
you.
do it the exact same way. With Transitions, we have an admission team. So that admission team will come out and admit that patient into hospice. That's typically when I say a long visit, it's a longer visit because we're meeting family or loved ones or guardians or whomever that may be, and we're creating the opportunity for people to ask those questions and say, why? Because oftentimes we go there and people don't even know why they are on hospice. The provider has just sent a referral over without really having that deep conversation as to why they may have chosen hospice for that patient. And so we have an admission team that will come out. And so when all of those questions are asked and folks are satisfied, then our clinical team will come out. And so our clinical team consists of a nurse, an RN case manager, a social worker, a CNA, spiritual care counselor. That makes up our team. So when I talk about having the four, that we are four dimensional, physical, social, spiritual, and psychological. That's the beauty of hospice, is that it hits all four dimensions 100%. So there's a space for all of those. When we talk about comfort care, it's not just physical comfort. We are making sure that all dimensions are just as comfortable as they can be.
Wonderful. And we did not speak about how this service is paid for. So can you address that? Because everyone is so concerned about medical bills and all of that nowadays. So tell us how this service can be paid for.
Sure. Medicaid pays for hospice services, and even private insurances have a hospice component to it. So Blue Cross Blue Shield, Cigna, Aetna, all of those, once a patient is on hospice, there is a hospice benefit. But Medicare and Medicaid is paid for. I will add that Transitions Life Care is a non-profit organization. So we are a non-profit hospice organization. So patients don't have to have any form of payment. They may not be on Medicare, they may not be on Medicaid, but we do not turn patients away if they do not have the ability to pay.
That's great. I'm really happy to hear that. So if they do have private insurance, it should be covered and everything should just flow.
Yes, let me just add, there is
Okay.
a caveat to that, so
Please.
people can really understand.
Okay.
Medicare, Medicaid, or any private insurance pay for anything that is related to the hospice diagnosis. So if a patient has dementia as a hospice diagnosis, but they also have diabetes, Medicare will pay for the dementia, everything that's related to the dementia. They may not pay the hospice benefit part of it, may not pay for insulin.
Understood. So that means that the diagnoses need to be listed on the hospice referral. Is that kind of what you're saying?
They can be, and then hospice makes that determination as to what hospice diagnosis that will be used.
Okay, all right. On that first visit or in conjunction with the primary care
that is
physician.
in conjunction with in conjunction with the hospice providers.
Great.
Because we have hospice providers. Once the primary care or advanced specialists make that referral, then that goes to our hospice providers. Then determines which one of these will be the hospice diagnosis.
Okay. Does the primary care physician stay involved after they come over to hospice?
They can. Once that referral is made, and that whoever did the referral, then they will get something back that says, "Would you like to keep this patient as your continue, keeping this patient on, or would you like for a hospice provider to keep them on?" And so we have many community docs that choose to keep their patients on, and then we have many that says, "You all are the experts. I am happy to hand that over to hospice providers."
Right. Well, I am so happy that we had this conversation today, because I feel that choosing hospice is something that you can think about even when you're not sick. while you're healthy, think about what that transition is going to be for you. How much, when you do your advanced directives, how much care do you really want, and what's going to happen
Yes.
next? It doesn't have to be after, you've been deemed terminal or whatever. So those of you that are healthy, young, whatever, listening to this, go ahead and start thinking about that. You don't have to make a final decision, but just know, as she mentioned earlier, we're all going to get there. Some of us will have a longer transition. Some of us will go very quickly. But if we have a long transition, this is something that we can think about and start to prepare our minds, because I think in a lot of cultures, we have to think about things for a really long time before we warm up to it. But just be open. She mentioned us being open about it as well. Dwan, I thank you so much, and I would like for you to give any final thoughts that you'd like to leave with our audience today.
Thank you. Just thank you for being open to having this conversation, because we definitely understand that this is not a conversation that is an easy one. It's not one that people would like or have a desire to talk about. But we do a lot of work in the community. And I always say either you're going to talk about it or somebody else is going to talk about it for you. And so we want people to be on the front end of it, so you have a say so in how this is part of life, and so you will have a say so in what your life has the potential to look like. And so I will say, be open, and again, be receptive. We got to start having those conversations. If it's just a small conversation, let it be small, but we do not have to be afraid to talk about it. So let's just talk about it. And we are happy to come out to support and facilitate those conversations. Feel free to reach out to Transitions Life Care and to us, just to say, I need help in facilitating that conversation. So thank you for having us today, and just to talk about it, and help people and help the community understand what it is and how to facilitate those conversations.
Thank you. And I'd like for our audience to know is this won't be the last time that you hear from Dwan. She and I would like to do several more sessions, because there's so much that we can delve into around this subject. And it is part of care, it's part of life. So we want to make sure that everyone is educated. Thank you all so much. And until next time, take good care. Thank you. This episode of Caring for You was produced by Homecare Resources Now, hosted and edited by Patty Williams, music by Eno Magno, used with permission. A special thanks to our guests. This podcast is for educational purposes only and does not constitute legal, medical, or regulatory advice. Thanks for listening. Until next time, take good care.